Dr. Brian Lishenga is the chair of RUPHA, and he's our guest now. Good morning, Dr.
Morning, Eric.
Karibu sana, good to have you here.
Asante, it's a pleasure.
There's a lot to unpack.
Yes.
From what you have been saying, what you said on Friday, what's been going on in the health sector. But before we get there, Jano is going to give you the day's quote.
Right.
You know the drill. The drill is she gives you the quote, then you tell us whether it makes sense.
Okay.
He's a bit nervous. It's like it's Monday morning, I'm the first guest. Must we start this way?
I've not even had my
No, it's very chill.
Quite easy.
It's quite easy. The person who said this quote is called Shailja Patel. She's Kenyan. She's a playwright, a poet, a political activist of Indian heritage, but born and raised in Nairobi. She said, Kenyans work 3 jobs to eat, and leaders call that resilience. Kenyans work 3 jobs to eat, and leaders call that resilience. Do you agree with her? What stands out for you in that statement that she made?
Ooh, I agree with her. You know, just a disconnect between the leadership and the reality of the common people. You know, the more you suffer, the tougher you are, and therefore you will be praised for suffering a little more. If you could work 4 more jobs, it would be even better. But I mean, I agree with her, and the challenge to leaders to really empathize with the citizenry. You know, if you say Kenyans are a hardworking nation, might not actually be a compliment. It just might mean that they are suffering, long suffering.
Yeah.
Wow.
Yeah.
How many jobs do you work?
Well, quite a few, but by choice.
by choice, not by design, no, by necessity.
It's not a survival imperative, which is what the quote is, you know, referring to. That it's just for basic of survival, you know, which is something that we have to address.
Right.
Indeed. RUPHA, Rural and Urban Private Hospitals Association.
Yeah.
What is it? Who are your members?
So, Rural and Urban Private Hospital Association is a non-political society of healthcare facilities. So, by healthcare facilities here, we're talking about the full range from medical centers, clinics, ambulatory centers, laboratory, you know, mental health centers, which are privately owned and are registered to practice or to offer care in the country. We have been in existence since the year 2019. So this is our 6th year of existence. We have a presence all over the country. We are present in 44 of the 47 counties. And our membership currently stands at about 728 healthcare facilities, which is a significant number of the private healthcare space. In fact, if you look at the level 5 and level 4 hospitals, our membership represents about 40% of the country's level 4 and 5 facilities.
Of private level 4 and 5 facilities?
No, countries. I mean, if you combine everything. Yeah, so Kenya has about, let's say for level 4s, Kenya has about 458 or something like that. We have, our membership there is about 250. So,
and you said in total is about 700?
728.
728.
Yes.
All right, let me begin with, our faith-based facilities part of RUPHA.
There are a few faith-based facilities because membership is voluntary. So we have a few faith-based facilities that are our members. And sometimes we also share members with other associations. So for instance, you have RUPHA members who are members of the Christian Hospital Association of Kenya and vice versa. You know, freedom of association, as we call it. So we do have, you know, shared membership. So sometimes our industry actions affect more than just private hospitals.
Very true. What's the mandate of the association?
So the association exists for 4 reasons. One is advocacy, which is what we have become really known of because of the reforms. So we focus on advocacy with the, you know, legislature, the executive, you know, all these people. So when there is policy changes or when there are issues that affect private and faith-based organizations, we speak about them. Like now, the SHA conversation has been quite a lot, and we have contributed a bit. The other issue we do is we do capacity building for our members. So, for instance, here we focus on issues like quality. We focus on issues like financial management, governance issues. We also do aggregation of demand, which is we bring together economies of scale and try and make sure that our members get commodities at reasonable prices, quality. And then we also do a lot of partnerships, which is the fourth pillar. And on partnerships, we try and bring in the entire health ecosystem, for example, equipment manufacturers, financial services companies, IT companies, anyone who interfaces with the healthcare system. We bring all those together so that they can have conversations with hospitals. So these are among the things we do. So advocacy is what we are, largely because it's the loudest, but there's so much more happening: training, capacity building, economies of scale. So all these things are part of what we do.
Okay. Now getting into SHA. Give us context for how the transition happened from NHIF to SHA, from the perspective of now rural and urban private hospitals and facilities. What were the pain points? What's the opposite of a pain point? The green points.
The green flags.
The green flags as far as this transition goes.
Okay. So first of all, it has been our consistent position, at least documented, maybe not spoken about often, that we support the transition from NHIF to SHA, largely because we know that Kenya's healthcare system is underfunded. There isn't enough money in the system to provide for the care that the Kenyan people aspire to according to the Constitution. So anything that, any reform that puts more money at the disposal of the healthcare system is any reasonable healthcare practitioner should support that. You do not want people walking into hospitals and incurring catastrophic expenditure. So we do support that. However, we did contribute a lot to what with ideas when public participation happened and we were asked to come. There's a difference between actually contributing and your ideas being put in, but we did give a lot of ideas. And so the green flags, as you said, maybe if I start with the positives, is that there was a genuine attempt to mobilize more resources, find money for healthcare. And so the idea that you would have a primary healthcare fund, a social health insurance fund, the SHIF, the emergency chronic and critical illness fund, those different baskets was fantastic, and we supported that, and also supported the idea that there would be, for the first time, government investment in health directly from Parliament, because these two funds, primary healthcare and the emergency fund, are direct, parliamentary appropriations, something that we did not have under the NHIF, which was 100% contributory. So the way we saw it is more money into this basket that we call healthcare, and we thought that this would reduce burden. So that was a major issue, major good point. Another good point that we felt very positive about is the reduction of the mandate. The realigning of the mandate of the social health insurance. So previously under NHIF, the NHIF was judge, jury, executioner. They did everything: inspected, licensed, regulated. And ideally, in an ideal situation, they should have just done payment of claims, verification and payment of claims, and let the inspection, the regulation of facilities be done by other bodies. So there was a serious attempt to make sure that the mandate of NHIF, now SHA, is clearly outlined. So that also was a green flag. The other one is digitization. So the big push towards having digital registries, digital records, all this. So these were green flags, things that we supported. And of course, the one that doesn't get spoken about often is just the opening up of the space to talk about our healthcare system. So the last 3 years, we've had lots of conversations about health. Health has been front and center. These are all good things.
Very true.
Now, red flags. Now, so red flags were a couple. One, we think the process was extremely rushed, okay? They seemed to be running towards a finish line without thinking through a lot of things. And we cautioned, and we are on record, we wrote to the management, we wrote to the cabinet secretary. We told them that while we support the introduction of all these positive things, we think that you need slightly more time to get these things done properly. And our suggestion was a 2-year transition, first out, would have been a more reasonable transition to allow them to do better housekeeping. That was not done. The other thing that became a very clear concern was the idea that everything NHIF was bad. So this was, so the demonization of NHIF, an organization that's existed since 1966, must have done some things right. It can't have been everything was fake, everything was bad. And we told them that please don't throw the baby out with the bathwater. Pick a few of the things that were done really well by NHIF and incorporate. But they seemed to have been an insistence that, just throw away the whole thing. The third problem was the model. Model was problematic. We told them, okay, so you have an ambitious plan to raise a lot of money, 250 billion, 275 billion at that time. But, we are not sure whether Parliament will actually put on the table its fair share of the budget. Number two, there was the extra dependence on the informal sector. So heavy dependence on the informal sector. At least in their modeling, they were saying that the vast majority of the money, somewhere like in the region of 70% of what the SHA fund required, will come from Mamamboga, guys on the street, people who are self-employed. And we raised a red flag, and it's going to be contributory. And they came up with a very interesting thing called proxy means testing. So basically, we'll find out from you how you live and how you spend, and then we will give you your premium. We raised a flag on that. We said in a country where 60% of the people are unemployed, it's going to be very difficult for you to get them to contribute voluntarily, let alone to tell you the truth about their expenditure. They will definitely, once they realize that if they tell you the truth, the premiums go up, people will lie. Yeah, of course. And then finally, it was the issue of primary health. So primary health had two problems. The model was wrong. I can go into details, but let me just explain this way. The sound bites right now are the perfect example. Go to hospitals, care is free. Just register, walk into a hospital, don't pay anything. It's free, and it should be free everywhere. The problem with that, and as we have seen, is because of these model issues I'm pointing out, SHA has been unable to raise enough money. So they are relying heavily on the employed. So guys with a salary are carrying 96% of the SHA contribution, yet they represent only less than 10% of the Kenyan population. So they are carrying 96% of the weight, they represent less than 10% of the Kenyan population. This is the major problem at the core of our financial issues, that the informal sector are being told register. Nobody wants to tell them contribute. It's not enough to just register. You need to also contribute. So they are bringing in how much? Maybe 600 million shillings a month. And this is out of 25 million Kenyans. It's very little amount of money. The salaried guys are bringing in 5.4 almost billion a month, and there are only 3.5 million people. So they are feeling the weight, and they are not consuming the service because most of them have, alternative insurance, employer insurance, etc. So the model is a problem we need to relook at. And these are the issues we raised.
You said is that a problem with primary healthcare?
Yes, so with primary healthcare, the idea is, so there's populist politics. Now, I have to talk here like, a healthcare advocate, far away from the politics. There's political statements that are very good. Hospital care is free, go. So this is fantastic because people will cheer. Like for the first time, we are just gonna go walk into a hospital and I will not have to pay. So, and Kenyans have been very happy about this. Now, the problem is this. 90% of the reasons why a person goes to hospital are outpatient reasons. What I'm trying to say is if you take 100 patients, maybe only 10 out of the 100 might require hospitalization, people who visit hospital. 90 of them will be given a painkiller or an antibiotic and they go home and they're fine, you know. So if 90% of the reasons why you go to hospital is free, why would you contribute? You don't have to contribute. You just walk in, walk out, walk in, walk. So Kenyans are accessing care. They're not paying and they are not contributing. So, you know, we are basically, you know, ramping up those numbers, but we are not ramping up contributors.
The contributions.
But I don't need to contribute to the primary healthcare fund.
You don't need to contribute to the primary healthcare fund. You don't, but your contribution is essential for the health of the SHA fund. Okay,
right.
And the SHA fund is the most cost-intense fund. The idea was we get a lot of healthy people to help us take care of the few sick people. This is how we sustain it. So it was carrot and stick. So we will hang you, this carrot is free outpatient. If you like it, you're going to contribute to the fund. The SHA fund, not the PHC fund.
Yeah.
You know, if you like what you're experiencing, you will contribute because you want to support this nice.
That was the anticipation.
That was anticipation. But human psychology doesn't work like that.
So how would you do it?
To be honest.
Because first you started by saying that you support the primary healthcare fund, taxpayer funded. You support the emergency, chronic and critical illness fund, which is taxpayer funded. You support SHIF, which is contributions. How would you then roll it out in a way that you would make people voluntarily pay?
Contribute.
Okay. Answer that by giving you a very good example. So, in the last year of NHIF's existence, at least the last financial records we have, which is the 2021-2022, the ones publicly available, I know there are others, the NHIF collected 7.2 billion shillings per month, okay?
Yeah.
For, you know, so by the time the year ended, they were around 86 billion shillings, which is amazing, okay? SHA, I've just told you, is doing between 5.4 and 6 billion a month. So in other words, let me put it this way, salaried Kenyans are paying 2.75% of their salary, isn't it? Which is much higher than they used to pay for most of them under NHIF. But guess what? And we have many more people registered now than we had under NHIF. But guess what? We can't even match the numbers financially that NHIF did in its last financial year that we have.
We get that, Brian.
Okay.
How would you do it differently?
So, the question is then, how did NHIF do it differently so that they were able to collect more money with a small contribution?
From less people.
And it was very simple. Every person who accessed NHIF outpatient services was a contributor.
Yep.
First do that.
Yes.
So, in other words, the day you fell out of your NHIF contributions of 500 shillings per month is the day, or the day your employer failed to remit, is the day you were not eligible anymore for outpatient. Now, there was an inbuilt incentive for employees to push their employers to remit, because once you stop remitting, my medical care is gone for outpatient. There was an incentive for the people who pay 500 bob to keep paying, because the day I don't pay my 500 bob, the day my portal turns from green to red.
Are you saying that primary healthcare shouldn't be free?
I'm saying that people should pay. You still pay for it by taxes.
Yes.
Okay. So what we need to do is to fund it the way we have funded it. But, for instance, limit access to those who contribute.
That has been a pushback from the public.
Now, number two.
Because people have been going to facilities and you told, are you registered for SHA? That as an entry to accessing service. And of course, that is for purposes of the registration purposes. Then the other one is, how are you contributing to SHA? Are you saying that you support that move?
There is no enforcement to, are you contributing to SHA? For primary
There's none,
health.
yes. Are you saying that there should be, that you should not access services in primary health facilities?
So this is option one. Option one, we say that if you are to access primary health care, okay, which will be paid for you because anyway, the state is paying. We are paying through our taxes.
Yeah.
We must have evidence that you are contributing.
Okay.
Okay. If we go back in history a little bit, this was actually the original idea behind the reforms, but it was defeated in the courts because of the issue of access to services.
Yes.
You can't get ID if you're not. You remember that that conversation?
Yep.
But we didn't have to go that way. The only way we needed to go is at the point of access, we confirm your contribution status. This way, we incentivize people to contribute.
That's option one. What's
That's
option two? Because I want to listen to option two before we come back and push back on option one.
Option one is a political live wire. The one I have just described. It requires very tough decision making. Okay. Option two was also tough, but just make a funding to SHIF, contribution to SHIF by earmark tax. So don't ask Kenyans to contribute per month. Just put a levy on a given set of goods and forget the story. Collect the money from everyone. So this was also our proposal, that you have a challenge. You have either a contributory system or a tax-based system. They went for a hybrid system. So now for these guys who are supposed to contribute, we have an unemployment rate that is extremely high in this country, so it's hard for people to contribute. But you need to collect the money for the SHIF fund, not for the PHC fund, for the SHIF fund. So how do you collect this money for the SHIF fund? You could actually just put a tax, like
a levy,
like the way we do fuel levy or road maintenance levy on certain set of products or goods or commodities.
Or 2% on VAT.
Yeah, something, 2%. and then just make sure that at National Treasury, that money cannot be touched for anything else except for the SHIF fund. And we say everyone who is unemployed in Kenya have contributed. That could be it, So the challenge they have now, that SHA has now, is that out of the 25 million Kenyans who are registered, informal sector, okay, it's slightly less. Let's say 23 million informal sector Kenyans who are registered. Only 1 million are contributing ever, but the other 22 million are dipping their fingers in the pot consistently. They're just getting the care.
I think the second one for me, sits a lot better than the first one, because the way our healthcare system is, or our healthcare habits are structured, if you don't seek primary healthcare, it's a domino effect, right? And then you're burdening the system going forward now, so that when you do need now, you end up needing either emergency and critical care, or you need higher levels of care when it could have been easy and preventative and, cheaper.
Got the problems earlier.
Much earlier. But let's take a short break. When we come back, we'll be talking with Brian Lishenga about RUPHA's call for, is it a strike notice? What do you call it?
Go slow.
A go slow notice.
How does the hospital go slow?
We will explain.
Watch our Rudy. We'll be right back after this. 100.
Yes, just before we get back into the conversation, Plano on YouTube says we need to move from viewing levies and taxes as a solution to every funding issue. Not everyone who pays for SHA uses or utilizes their contribution. What happens to such contributions?
That's the point.
But that's the exact point.
Social health.
It's a pool of money. It's a pool. And then you dip
in fact,
when you need.
We want more people who are not using it to pay, so that we can take care of the few who are critically in need.
Yes.
But that's the idea behind it. And
right.
You will not be using your healthcare SHA at every point every day in your life. But when you do need it,
you really need it.
Yes, you do need it.
You do need it. So that's the plan. The perception is what's falling through the cracks. So how do we rectify that? Because I think his reaction is, why is it? It seems like you're compelling me to contribute and pay more. That's the way people. So how do you reconcile that perception to make it make sense?
To be mandated?
Yes.
I mean, how has it worked in other countries, Brian? Because we have other countries which have universal health and social health contribution, and everybody is contributing into that kitty. How do they not complain?
They complain a lot. I mean, they complain. If you look at the UK, for example, which is totally tax funded, you know, so nobody actually contributes. So people have moved away from complaining about contributions. They are complaining about long waiting queues in hospitals, you know, expensive procedures and things like that. If you go to other countries like the Nordic countries, you know, which also don't contribute, the complaint is the tax is too high. But you see, like in the Nordic countries, they accept that you cannot have state-of-the-art care without contributing. So what has happened in those countries, like the few where it has worked, like Norway, Sweden, you know, the Netherlands, is although people are taxed very heavily, the value for money they get is so good that they can accept. Okay. You know, so maybe that's where we need to go, and we need people to understand that there is nothing like free healthcare. It doesn't exist. We have to pay for healthcare somehow. It's just we as a country, as a people, just need to decide which pill can we swallow. You know, can we swallow the pill for contributing from our salaries, or do we swallow the pill of higher taxes and we get healthcare? And then once we've taken our pill, we hold our leadership to account to actually deliver this service. This is really what it. But there is no. And in fact,
there's a pill either way. It's the size of the pill.
I was going to say this. One of the
small one, makapchus.
Lazima umeze hiyo.
And Kenyans don't have a problem with swallowing the pill. It's that effectively you don't really get what you pay for.
Exactly.
I think that's what it comes down to, right?
So this is the disconnect. And one of the criticisms that private sector has gotten, and maybe I can address today, is you're too expensive. You know, you go to hospital, private hospitals just want money. They just want to take things. And granted, I have to say this, you know, it happens in every industry. There are hotels which you don't like. You think the food was too expensive, but the quality wasn't great. You know, we have this. Or, you know, you take an Uber and you're paying a fee and you're like, this Uber, imeisha, imechapa, how am I paying all this? So every industry has situations where you don't get value for money. And health is not an exception. We have hospitals that do a bad job and they just get money from people. And a lot of them are private, public, and faith-based. Even public hospitals, people complain that I go there, they ask me for this, and the service is not there. So let's accept that we have a general problem. But I want to mention this. The cost of care in a public hospital, KNH, for example, is comparable to the cost of care at Aga Khan. And let me just explain. The fact that you walked in there and you are not given at KNH and you are not given a huge bill doesn't mean that KNH has less costs than Aga Khan. It is just that somebody else has paid for those costs through taxes. We are all paying, you know. So the cost is the same because the doctors are the same. They charge the same fees. They have to be paid the same salaries. So we are paying. The only difference is that at which point are you paying? Are you paying at the taxes point or are you paying at the service
consumption point? Okay. So let's come into RUPHA and the issues that you've been raising lately. You've been raising issues of non-payment of, first of all, arrears from NHIF and now the current ongoing rollout of universal health coverage. Let's start with the arrears. By the time SHA was being rolled out and NHIF was being wound up, there was a 33 billion shilling universally acclaimed debt. And the Minister for Health then, Dr. Baraza, came and said, you know what we are doing is we have gotten money from the National Treasury and we are paying these bills. When I look at your statement, it is still mentioning the same figure.
First, I want to put it on the record for the nation.
Okay.
Not one bob or even a cent of that 33 billion has been paid to any healthcare facility, including your local dispensary, your local health center. They have not received ata shilingi moja. Nothing has been paid. This, the president came out on 5th of March and said, he issued a statement. It's still available on all his official handles. He said, we will pay NHIF debt 10 million and below, we will pay immediately.
Yes.
Okay, no, he gave the number.
Yes.
And he said anything above 10 million, we will have 90-day verification. And whatever is clean, we will pay. Those are very reasonable statements. And if you recall...
Considering most hospitals fall within that less than 10 million.
Yeah, exactly. As we say in our statement, 2,500 odd hospitals or something are below 10 million. So this is most of the hospitals. It's only a few where you are now going to do verifications, not very many.
Okay.
So what then happened after the president issued that statement, there was a radio silence. There was no attempt to pay whatsoever. So there is no cent, nothing has been paid. Oh,
this is since March.
But there was an excuse. There was an appropriate, what I call an excuse. The appropriate excuse was there was a court case. There was a litigation. One of our colleagues, a doctor in Nakuru, who is, you have had him on the show, Dr. Gikenyi.
Yes.
Gikenyi went to court and said that he argued that the cabinet secretary cannot audit, cannot form a committee outside of SHA to audit claims inside SHA. There was arguments of patient data, being leaked out. And there was argument that auditing is a function of the Office of the Auditor General. The court sided with him, okay? That litigation first had a conservatory order on the ones which were supposed to be verified. Now,
not on the other...
Not the other
10.
Not on the less than 10.
So the 2,500 facilities should have still gotten their money.
Should have still gotten their money. Although I should say this, our colleagues in the churches, the bishops went to State House around that time. When they went to State House, the president told them, because we talk about these things, they told them that we were in a physically constrained space. Even that money required, the 10 million and below, which has been calculated to be about 5.3 billion, was not available at the time. So His Excellency, the president, told them, you guys give me up to after the budget, September, we will pay. So we are in September. So in our view,
So none of the legacy NHIF debt has been paid.
Ata shilingi. And I want to explain this. So again, when RUPHA is speaking out about legacy debt, we are getting a lot of backlash from people who don't understand. They think that we are asking for it because of private hospitals. No. We are asking for legacy debt because of the entire health system. I'll give you an example. In my home county where I come from, Kakamega, the county referral hospital of Kakamega is owed 175 million. In NHIF debt. My local hospital in Butere is owed 25 million. So between those two hospitals, they are owed 200 million. I want to ask the citizens, if those two hospitals in Kakamega were to receive 200 million shillings tomorrow, what would that do for equipping, for reagents, for drugs, for things like that? So, and most of the private hospitals that we are speaking about, I have the list of data of the debt. Some of them are owed just 100,000. It's not that we are fighting because of this. It's the entire health system. If one set of hospitals is not being paid, we feel the ripple effect everywhere. Because if public hospitals cannot treat patients, patients end up coming at night on emergencies in private hospitals, very critical, and we lose those babies, we lose those mothers. So the entire health system needs the funding.
Now, those are legacy NHIF debts. Now, we have SHA debts.
Yes.
As far as
and then we have
the ministry is concerned, I thought, and several people have spoken to this, that SHA was up to date with payments, including the cabinet secretary, right? I did not imagine that. Where is 43 billion shillings in debt coming from?
This is not the SHA debt.
Yes, this is SHA.
Since November last year.
Yes,
I want to give SHA credit. See, sometimes people think that when we are having these back and forth conversations, we are enemies. No. You see, in fact, we do talk a lot with SHA, the leadership. So so we have not been agreeing a lot recently, but let me give credit this way. The 53 billion that Honorable Duale mentioned has been paid. Okay, so this money has been paid in claims. Now, the question would then be, and we have challenged them this, we have said, it's not enough for you to put on your public web portal how much you have paid every hospital. which is great. By the way, we are one of the green flags is the transparency around who we have paid. And this is how we have also been able to unearth
if the website is still online.
This is how we have also been able to unearth the ghost facilities, because we as an association have also pointed out to them that, hey guys, you know this hospital you are paying, us guys in the sector don't think it exists, we know it doesn't exist. So the transparency is good, but we still want the CS and SHA to go a step further. Don't just publish how much you have paid X hospital. Publish how much they have claimed. Okay? Publish, you see, when you make that list, say, claims submitted by this hospital, 5 million shillings. How much we have paid them? 2 million. We are at 40% payout to this hospital. We still owe them 60%. Very clear. Nobody argues about that. The hospital, if it has a disagreement, can go and say, okay, I thought I had more money, etc. But since inception up to the end of August, SHA has raised claims worth, hospitals have raised claims worth 96 billion.
This is RUPHA hospitals?
No, Kenyan hospitals. Kenyan hospitals.
And the 96 is from primary all the way to...
No, SHIF fund.
Only the SHIF fund.
SHIF fund. And this, and Eric, this is why I started by saying the SHIF fund is our biggest problem. If we don't fix the SHIF fund, it's going to bring the whole house down. Because, you see, we've raised 96 billion in claims over 11 months, okay? And we have collected roughly at best 65 billion. So you see we have a 30B shortfall. Now, let me push a step further here. The payment, as you were saying, the minister said they're up to date. Let me explain how they arrived at up to date, accountants, mathematics, how they did it. So, first of all, we have the 90-day rule that claims are paid within 90 days. So the way they look at it is clever accounting. So the way they look at it, anything that is less than 90 days is not due.
Anything that's less than 90
it's okay.
days
It's
due after 90.
It's due after 90 days. Now, let me...
Brian, can I pause you there? Don't lose your trail of thought. Don't lose your trail of thought, because we were going to bring a caller in called Jeffrey. I didn't want to lose him, but we've already lost him. Apologies. Please carry on.
No worries.
Amerudi. Jeffrey from Bungoma. Good morning. Do you have a question or comment to make today?
I do have a comment. A lot of contributors who are actually ensuring that every month that their premiums actually goes to the authority, when they go to the hospital, they do not go in the inpatient department. They actually go in the outpatient department. And I want to give you a perfect example of my people going to the hospital, in a public hospital. They were supposed to be doing some ultrasound. They were supposed to be doing some x-rays as well. They were even sent to the laboratory. When it came to that, they were told that they have to pay cash. You can imagine that. And of course, I understand the reason as to why they were being told, because the guys at the public hospital were telling them that SHA will actually be able to reimburse them 75 shillings for the outpatient department. And I was like, 75 shillings? And the government wants you to go to the hospital in outpatient department, you go to the laboratory. In the laboratory, you realize there are reagents there that needs to be bought. There is no way 75 shillings can actually be able to buy those reagents, can be able to even buy the films if you want to maybe do the x-rays, even the ultrasound. So I think the government needs to sit down and revert back to how the NHIF was functioning. Because I remember back then when we used to go to the hospital using NHIF, in outpatient department, some of these services were being covered. Right now, a lot of people who are going to the hospital are going in the outpatient department, and most of those services, it is not being paid for by SHA. We are being asked to go into the pocket and pay for those services. And that's why a lot of us are saying that SHA is not working, because majority of us actually go to the outpatient department. We do not go there and then they are redirected to the inpatient department. So if that one can actually be looked into by the government, I think we could actually be able to make a good step towards ensuring that maybe the health care system actually works for the betterment of the people.
Jeffrey, could I ask you a couple of questions?
Yes, sir.
So, to the best of your knowledge, and you sound like you're knowledgeable enough, when people go into a level 2, level 3, which is primary health facility,
yes,
you're saying that the reimbursement is 75 shillings. Is it for all services or is it for lab services?
Generally, from my understanding, it is supposed to be for all the services in outpatient department when you go to that hospital.
Brian, is that the case?
So what he was told by the hospital or whatever they have had is based on what is in the SHA contract. So the budget is like this. For every registered Kenyan, this is the budget from Parliament. For every registered Kenyan, Parliament will appropriate 900 shillings per year for their primary health care. Now, so that translates to roughly 75 bob a month. Okay. Now, obviously, the reimbursement to hospitals is not 75 shillings per visit. There was, when we started out this process, there was a lot of misunderstanding around this in March and February, and we were able to iron out that. So what happens is, we are using something called global budget. So global budget works like, so Mombasa County has 500,000 registered people. So the budget that is given to Mombasa per month is 500,000 people times 75 bob. Okay, for primary health.
For primary health.
Okay, that is how it works. I don't know how much that works.
But of course, not all 500 are going to the hospital that month.
Exactly. So it's 500,000 people times 75 shillings. That's your money, and you will understand why the push for registration. Because the more a county has people registered, the more that number works up and up and up and up. But that number is not. Remember, it's not contribution. That's parliamentary.
That is
budget.
tax.
So even the 13 billion that's been allocated for primary healthcare this year is based on a projection of the number of Kenyans that would have registered by the end of 2025. And therefore, based on that projection, we have put an amount of money. Now, what happens practically at the hospital? At the hospital, what happens is, and if I can track back, when this started, so the hospitals share all this money. So if you have, back to Mombasa County, back to Mombasa County, so you have your money, 45 million a year. I think you can work out to how much a month. I mean, 450 million a year, how much a month? You can work out to that. So what happens is they ask themselves, how many hospitals offer primary health care in Mombasa? Contracted. So they could be 100. Your budget, should, let's say, is 20 million shillings, or let's say 40 million shillings for the county per month. These 100 hospitals will share that 40 million based on the volume of patients that came to the hospitals and the diseases they had. So if your hospital saw most of the sick people in Mombasa that month, ideally your hospital should get more of the money in that.
And now, just pause again. Apologies. First of all, there's 2 times we've asked you to pause. There's the other one for the calculation and what you were just saying. But Lucy from Embu is on the line. We don't want to lose her. Lucy, good morning. Do you have a question or comment to make?
Hello.
Yes, good morning.
Good morning. Okay, I'm Lucy from Embu. Hello.
Yes, we can hear you, Lucy. Go ahead.
Okay. I wanted to contribute and say this. I'm a healthy worker. And I deal with patients. And do you know the reason as to why they say they won't contribute is because as for NHIF, they used to go to the hospitals with their card registered and having paid. But for SHA, they are limited to dispensaries and health centers. And then someone, since one was born, knows that level 4, level 5 is the only hospital they can attend to. If they would be allowed to act like the way NHIF was doing, I assure you, everybody in Kenya will contribute. That is my point.
Okay. Lucy, just a quick question. So you're saying it's because people, like if you're used to going to a level 4, level 5, it's hard to now go to the dispensary.
Yes.
But is that a problem with how we've educated people? Because as a healthcare worker, you know some things should be taken care of now at a level 2, right?
Yes, we do tell them, but there are those who are resistant. Seriously, they say, why am I paying?
If I can't go to a proper hospital. Okay.
Yes, and again, there are those people who have been transferred. They have the chronic illness. like diabetes, hypertension, they are referred to the dispensary and health center. And yet, this dispensary health center, some of them, they don't have the diabetic, hypertensive drugs. So if you refer such a patient to the health center dispensary, surely, what are you doing? They don't see the need of paying.
Okay. So people are getting downgrade. Okay. I see your problem. Thank you, Lucy.
Okay.
Okay, thank you.
Lucy makes a valid point. So I'm looking at some of the data here that we have for claims, okay? At level 2 and 3, 80% of visits since SHA started happened to private hospitals, private level 2s and level 3s.
Those are those local hospitals.
So the question is, the point I'm trying to make is Kenyans, and SHA has this data, when Kenyans are choosing which dispensary and health center to go to, 80% of them are choosing to go to private or mission, level 2, level 3, because that's where they have been capped. But the question I'm trying to say, and government is only doing between 12 and 16% of visits. So the question I'm trying to pose here is, how are our governors and counties addressing the issue of public confidence at level 2 and level 3? Because it seems that our people have distrusted the entire public health centers and dispensaries. They are not going there. And the data from SHA shows it, that when you go to level 2, level 3, Kenyans are choosing to go to mission hospitals and private at dispensary health center over going to public healthcare facility. Because
or to go to level 4, 5 for smaller things.
And then, or they go to level 4, 5 and pay cash out of pocket because they cannot access primary health there. So this is the challenge we have. So most of the visits are actually not going to public facilities.
People are not going to dispensaries and health centers.
They are not going.
There's also the issue of distance as well.
Yes.
Because you can imagine that private health facilities will, be established closer to people. And the public health facility in one area is one. There's Kimana Health Center. It's in one place, but there are very many local that are closer to
health centers, dispensaries, private. And this is really what the data is showing, that that Kenyans, and that is also contributing. And she's very right; it's contributing to the unpopularity in terms of value for money. Because again, when these Kenyans go to the private and the faith-based level 2s, level 3s, the likelihood that they will incur an out-of-pocket expenditure is slightly higher than if they went to a public health center.
And my question is why?
Because of our cost structure. Remember, let me just explain this. Reimbursements, and people have been arguing about this, reimbursements from SHA are the same regardless of who owns the hospital, or your ownership structure, or your capital structure, or your funding structure. So whether you are a private hospital or a public hospital, that 900 shillings per person per annum applies to you as well. Now, they have nurses, they have doctors, they have rent, they have power. So the reality is, what we're saying is that the cost of care is slightly higher. The actual cost of care is slightly higher than the actual reimbursement. But now, how are public facilities able to absorb this so that they charge out of pocket less? They're able to absorb this because, guess what? Through our taxes, we pay the nurses' salaries. Through our taxes, we pay KEMSA for drugs. So the public hospitals are absorbing this cost, the extra cost, much better, and therefore not transferring it to patients as much, but they are transferring indirectly through our taxes. The private and mission hospitals, they are looking at the reimbursement and they're saying, okay, I can't meet my costs within this. And that's why the other caller was saying, you will be asked to pay for a lab, an X-ray, etc. In fact, we argued with SHA a lot about this. The contract, what the contract promises people and what the money can deliver are totally different.
Okay, we need to take a break. There's so many places, so many pending issues. Because I was also going to say, when it comes to, it's not just public confidence then when it comes to a lot of these public health facilities. He raised a very good point. It's access points, it's many things. So it's beyond just trying to enable people.
Information from these members.
Exactly.
Because your members are creating another impression.
That's true.
That it is SHA that's not paying, yet it's your cost issues that are raising an issue.
We should address that.
We should address that.
We should address that when we
And
come
the
back.
clever accounting again, because if you say there's a 90-day window, then there is a 90-day window. So if it's not You can't call it a debt yet, can
yeah.
you? Hold on.
You called it clever accounting.
He called it clever accounting.
It's the clever accounting.
I think we should come back to that.
Invoice
Yes.
is valid after 90 days.
Yes,
Yeah.
and then the ultimatum. So quite a number of matters to go over with Brian Lishenga, who is the chair of RUPHA. It's coming up to 8 a.m. Yes, to 8 a.m. Fixing the Nation, one conversation at a time. We'll be back for this conversation in just a moment.
Dr. Brian Lishenga, the chairman of the Rural and Urban Private Hospitals Association, is our guest. The association on Friday issued a 14-day notice that they're going to have a go-slow because of several issues. But as we're going to the break, Dr. Hari, you are responding and also explaining a couple of things. Number one, how you are hospitals across the country, private, faith-based, public, still owed a lot of money by SHA. But you said that SHA has been paying.
Yeah.
96%, 96 billion shillings.
In claims.
In claims.
Paid 53 billion.
53 billion. And the rest?
43 billion is outstanding. Now, there was an idea we were discussing about clever accounting. Just to explain that, because obviously I expect that SHA or the ministry will refute some of the things we are saying. But let me just explain that 26 billion out of that 96B is younger than 90 days. So it is in pipeline. Okay? So that means that about 69 billion is due for payment as the time we are talking. That is older than 90-day debt. 26 billion is younger than 90-day debt. Okay? So now, out of the 69 billion, SHA acknowledges the one that is valid, due, that they have paid 53 billion. Just quick math, that is going to leave us with about 16 billion unpaid, isn't it? Now, this is where our problems with SHA start, and not our problems as private hospitals. This is the problem of the health sector. You know, some of the questions I hear people asking is, why doesn't Kenyatta National Hospital, for example, complain? Kenyatta National Hospital is not a member of an association. And how would it complain when it receives 20 billion from the National Treasury every year? It can't complain. But the point is, there is 16 billion that is due contractually that is unpaid. Now, where did the drama start? This is where drama started. Cabinet Secretary Aden Duale shows up on a bright morning and announces that he has rejected 10.6 billion worth of fraudulent fake claims, to use his words. Now, that 10.6 billion that the Cabinet Secretary declared that he has rejected, you know, is money that is being slashed out of the 16 billion outstanding.
Yeah.
So what is happening is that you wake up one morning and 10 out of 16 is what? Maybe about 60%, okay? You wake up one morning and 60% of your outstanding is declared fraudulent and unpayable. So this contention number one. And just to make it clear, it is not money to private hospitals, money everywhere. Like, for instance, it's on public record. When they were in Kakamega recently, just this other week on the St. Mary's issue, they explained that out of that 10.6B, 22 million belonged to Kakamega County. So nobody's accusing Kakamega County of fraud, but that was rejected. Now, what we disagree with SHA is the idea that you can wake up many months after claims. These are past over 90-day claims. Many months after claims have been submitted, processed in your portal. Status in the portal is for payment. In fact, most of these claims had already reached accounts. They were for payment. They were not transitioning. Hospitals are waiting for payment. You know, they have gone through checks.
That you can wake up and call them fraudulent.
So one morning, people wake up, and actually on a Sunday, and you check your portal, and your due for payment claims have shrunk by more than 60%, and all that money is dumped under rejected. Now, hospitals are definitely up in arms, and I think the Kenyan people should be alarmed by that, because, I mean, the argument was these are ghost claims from ghost facilities. We have pushed back and said, Honorable Duale, if 10.6 billion came from ghost hospitals, No problem, no problem. You went ahead the next day and you published a list of 24. You said 24 to DCI, that investigation completed. Then you said another 61 investigation ongoing, that's 85. Then you had 998, which you said you have closed, okay? Now, let's take the 998 out of the equation, because the 998 should not even be discussed, and Kenyans should not be taken for a ride for the 998, because the 998 have not existed since 2022 as hospitals. They don't exist. So this was purely PR.
Again, but they were receiving monies.
No, they don't. Okay, maybe. Who knows? Because we have a problem with a porous digital system. But these 998 facilities, we know as health, and KMPDC can confirm, that they have closed these facilities for various reasons. Some of them lack staff. Some of them even closed, by the way. Do you know some of those hospitals, they wrote to us and said, I saw my name on that Gazette notice, but here is our letter from KMPDC, which we wrote to KMPDC in 2022, telling them that we were winding down that facility because we don't want to play in that space anymore. So this 998 was showbiz, because these are a lot of hospitals that had already been flagged by the regulator.
For various reasons.
Various reasons.
So they're already closed before this year?
They're already closed. They don't exist. They don't even have licenses. They don't exist. If somebody was paying them,
that is now another issue.
Separate issue. That one now is a function of audit. But now let's go to the 85, 24 plus 61, who are being investigated. Now these are the hospitals which are claimed to have submitted claims worth 10.6 billion fake. What we have challenged the CS. Okay, just don't do that. Go a step further. In fact, we as RUPHA are very keen to know if out of these 85 fraudulent facilities, how many of them are our members, okay? We would like to also, because all our members sign on an anti-fraud policy when they join us. To your question of whether our members are ghost, they sign. One of the things, criteria for membership to a hospital association is not only RUPHA, also the Kenya Association of Private Hospitals, the Christian Hospital Association of Kenya. We have stringent criteria. When you want to onboard, you have to show us your KMPDC license. You have to show us that your people are validly registered. You are maintaining your SOPs. All this is part of onboarding. You don't just get onboarded because you say, hey, I am a hospital. No, we check due diligence.
So RUPHA goes to the facility.
I'm
claiming to be a dispensary, but there's nothing.
So for instance, today, if you claimed that you are a level 4 hospital in somewhere in Nyamira, and you wanted to be a member of RUPHA, so first of all, we'll ask you for all your registration details. If you are registered as a company, we need a copy of your certificate. We need a copy of your KMPDC registration and year's license. Who are your superintending doctors? We ask you to send us their copies. So we file everything, due diligence, your PIN, all that. We have a database for all these guys. And then we do county visits every year. We walk around the counties, we go visit these hospitals. But here's the thing, we also self-regulate. So for instance, in Migori, we have maybe 60-something hospitals that are our members. Any hospital among them masquerading will be flagged out by the others. Because guess what? If the hospitals know, if a fake hospital is getting paid, it's taking away from me a genuine hospital. So the first whistleblowers are actually your core hospital owners. They are the ones who whistleblow on you. They say, that hospital, they say that they do orthopedic surgeries, they have nothing.
So no ghost hospitals is what you're
in our association. In our association. But I want to explain the idea of ghost hospitals here. It's a very interesting idea. The idea is this, that these are hospitals which don't exist or don't have the functions that they say they have, and yet they have been paid. And they have been paid, in some cases, hundreds of millions of shillings. By the way, that information is also available, and SHA knows these hospitals. How does a hospital become a ghost hospital and get paid? First of all, what is the criteria for getting paid? One, you must be KMPDC registered and licensed. So, and how does KMPDC license you and register you? The law requires that these KMPDC guys have to do an inspection, okay? This inspection is usually a joint inspection. It's done by KMPDC, the laboratory board, the radiation board, the nursing council, and the county officials. So these guys go to the ground.
So it's It's five different entities.
Bodies. And even in law, we introduced another one called the Kenya Health Professionals Oversight Authority, KHPOA, which unfortunately we have refused to fund, but it is the one that is supposed to coordinate joint inspection.
Okay.
Now, they go to ground, they look. Okay, you said X-ray, what, they look, they sign, they give you a clean bill. The KMPDC issues you with a registration certificate, and then they issue you with a license to operate. Now, on the
categorizing you as 1, 2, 3,
yes,
3, 4,
5, whatever, based on what they found. And also, remember this, KMPDC has the license of doctors. Nursing Council has the license of nurses. When you present a list of doctors as working at your hospital, KMPDC actually checks whether they are licensed to practice. And the KMPDC license actually reads at which hospital you are supposed to practice.
Okay.
So, and you cannot have 2 licenses, like here and there and there.
A doctor is attached to one facility.
They are licensed to practice at a particular place.
Okay.
Okay? So this is data that they have. Now, KMPDC is supposed to share this data with SHA. Hence, you know, the whole story of we have digitized records, now we just pull data, we don't have to get hard copies. Fine. So once SHA gets that, SHA contracts the facility. You know, so SHA is basically, SHA relies on the word of KMPDC and the joint inspection that the facility is valid and it can be paid, and we saw with our own eyes. Okay, so SHA says, wow, good, so we have gotten this. They start, so when they receive an invoice for a surgical procedure, they check against your license, says level 4, 2 theaters. Yeah, these guys can do this. They honor the invoice. Essentially, they pay the invoice. Now, then there is the Digital Health Agency, which is now supposed to help these guys share information. Now, a ghost hospital can only exist if this entire chain failed.
True.
That's the only way a ghost hospital can exist. The chain must fail from KMPDC, from joint inspection, from all the... So, today, if you are to say blame a certain ownership of hospitals for being ghost, we must start at the point of where did the rain start beating?
Who licensed you?
Who licensed you? Now, I will go as far as saying that I don't want to drag KMPDC under the mud, but I would say that we have defunded KMPDC year after year. We have defunded it, we have reduced its capacity to do work. This year alone, if you check the budget that was appropriated for KMPDC, they had to literally lobby for Parliament to put money, because Parliament had withdrawn even the 200 million they had requested. They had to lobby hard and they ended up getting only 180 million. Now, we are saying an organization that is supposed to inspect, accredit,
all
license 14,000 facilities in Kenya and keep checking on them, we are only funding it to the tune of 180 million a year to pay its staff, pay its salaries, pay everything. It's not possible. So obviously things are going to fall out of the cracks. So what we would urge our political leaders, and by the way, that's half the story. There is no single public facility that I know of at these lower levels that undergoes joint inspection.
Just hold that thought before we go even to the second part. We've got a caller. I believe the name is? Sorry, Phil? Okay. I don't think we've got them. Oh, from Nyamira. Okay. What's their name?
Stephen, I think.
Stephen.
Yes.
Good morning, Stephen.
Good morning.
Very good to hear from you. What's your question or comment?
Comment yangu ilikuwa kuhusu SHA. Nilikuwa na wazo kuhusu wenye marafiki zangu wenye tulikuwa tunalipa NHIF hapo kitambo. Ile shida tuko nayo ni kwamba hii SHA wanatulazimisha tulipe annually. Sasa na kipato chetu unapata mtu ana hand tuseme ni 5,000 per month, ile pesa unapata tuseme kwa hii biashara ndogo ndogo ya watu boda boda. So inakuwa vigumu kulipa hiyo SHA mwaka mzima kulingana na mapato yetu. So tungependa serikali tuonee huruma, waweze kutukubalia tuweze kulipa SHA monthly venye tulikuwa tunalipa NHIF kidogo kidogo. Hiyo itatuwezesha na sisi pia tuweze kutibiwa na SHA. Sasa hii kusema tulipe mwaka mzima.
Steven, yes? Walianzisha hiyo kitu ya lipa SHA mdogo mdogo.
Pole pole ama mdogo mdogo. Lakini
so walianzisha, lakini
mimi yangu hata saa hizi wananitumia message wananiambia nilipe miezi 4.
So
miezi 4 kwanza.
Haujasikia hiyo mambo ya lipa mdogo mdogo?
Bado hiyo hakuna. Sasa mimi kama mimi nahangaika sana. Hiyo ndio shida yetu.
Hiyo message ilitumwa lini? ya kulipa 400?
Wananitumia nilipe miezi 4 kama imeshikana.
Miezi 4 imefuatana. Okay.
So hiyo inakuwa vigumu kwangu.
Sawa. Asante Stephen.
Matters communication, as you normally say. You have another point before we go to the go slow because of time.
We're heading there into that go slow.
So Steve is right. Steve is right that the LIPA SHA Polepole is not working for 2 reasons. One, public education has fallen short. We haven't done enough. Yeah. Number 2, the LIPA SHA Polepole is still a 4-month upfront payment and then a loan. So that's what it is. Let's just say, so he is very right, Steve is very right, that when you sign up for LIPA SHA Polepole, your premium says 10K, 10,000. You are required to pay 4 months in advance, and then you will be given a loan.
You're going to
for the remaining 8 months, and then now it is the 8-month loan that you are paying Polepole as you service your debt. So what he's trying to argue is that for most people wa hapa chini,
your 4 months,
hata hii 4 months hawana, so they should revert back to the way they were paying monthly, month after month.
Okay. Back to the issue of, the unpaid bills. So you are taking issue with the fact that 16 billion shillings is what the hospitals were waiting to be processed. Then the minister says 10.6 billion of this was fraudulent claims. You're saying there's no fraud?
The problem of fraud has been quantified. Even in the statement by the cabinet secretary, he said the global problem of fraud is somewhere between 5 to 15% numbers. So within the context of SHA, they are suspecting that somewhere between 5 to 15% of claims are fraudulent. We have criticized them for not giving Kenyans value for money because we don't expect SHA, with the investment that, let me call it the consortium.
Taxpayers are putting.
They are putting in a lot of money, 100 and something billion. We think that if you're putting in that kind of money to fight fraud, medical fraud, you shouldn't be shooting arrows in the dark, because what they are essentially doing is that they don't know where the fraud is. They cannot tell where the fraud is.
They do. You've just said 85 facilities.
Right.
24 files completed, 100 to the DPP.
Eric, that's where we are challenging them.
Not DPP, but the police.
DCI. We are challenging them this. It's not enough to say 85 hospitals are fraudulent. Publish against the 85 hospitals the amounts of money that you seek to recover. And that's why we're also going a step further and saying don't publish payments only, publish also claim information, because
and where the fraud is.
And where the fraud is.
Some examples that the CS gave was there's a facility here that has one patient there's a claim against one patient for more than one service. And they're saying, surely this doesn't make sense. Which is, this has always been there. One name, and then you appear, they had this service, they had another service.
3 knee replacements.
Yes.
So this happens all the time. But what we are trying to say is that, and it happened also during NHIF. So when the last investigation for fraud in NHIF yielded 178 million, I'm just trying to tell you how complex this problem is. It yielded 178 million. Today, and that time they were saying, Susan Ahumicha, the CS, said 20 billion had been stolen from fraudulent claims. So we said, okay, Honorable Secretary, if you know it's 20 billion, publish against the hospitals who have stolen the 20 billion. She could only pull out of her hat 178 million Kenya shillings. And that is the problem Honorable Duale has. Honorable Duale has 85 facilities. 85 facilities cannot explain 10.6 billion. So and by the way, I've looked at the data here. Do you know our largest hospitals, level 4 to 6, biggest hospitals in this country, they, out of this 96 billion that I'm saying, they claimed 40% of that money. 40% of that money. And these are less than 400 hospitals. 40% of that money. If you are looking for fraud, you know where to start. You can't...
But it's very easy to explain that, in my view, because of the level of service that they offer and the level of care. It's a lot more costly than below that. But just before you go into that one, are you saying that of these 85 facilities, none of them is a RUPHA member?
That's why we are asking him to publish the names.
You don't know. You don't know what 85 are.
Where? We don't know.
He just said 85.
We want him to publish the names. In fact, on the point of DCI, by the way, on the point of DCI, and we think Aden Duale should minimize theatrics, because, why would he take 85 files containing people's medical history, containing people's data. I'm sure maybe there's an MP there who has had a procedure done. Why would he take those files to DCI? You know, anyone can contest this. What the law requires is that when you have fraud suspected inside SHA, within SHA itself, there is a mechanism to investigate, to fine, to even take, you know, this has not been exhausted. So put theatrics aside. There's something called a dispute resolution tribunal, which is established in the law that is supposed to investigate such things. Why is that tribunal 1 year into SHA not in place? And then we take very serious medical information and we lump it at
What would that look like in practice, very quickly, the dispute resolution? What would it...
So essentially, when there is a disagreement, like suspected fraud, between a facility and SHA, so SHA can take action against a facility, isn't it? If a facility feels aggrieved by the action, that they, you know, they have not been given the right to be heard, you know, they would say, okay, fine, we have been flagged for fraud. We will take our case to the dispute resolution tribunal. Then SHA will also bring its case there and say, this is the reason why. This tribunal has experts, you know, people who can comb through the data and say, okay, fine, you are actually fraudulent. You get what I'm saying?
Anecdotally, of the facilities that we have seen just not making sense, right? Whether it's level 2s receiving tens of millions of shillings and things like that, none of them is also a RUPHA member?
We have actually flagged a lot of facilities, even on our X handle, that have been receiving money suspiciously. But let me take this problem higher for you. Level 2 hospitals, out of the 96 billion, do you know how much they have been claimed from SHA? 2.9 billion. Now, let me explain something, why that is odd. It should not be odd for me as chairman of RUPHA or as a private sector. It is odd because level 2 hospitals are not supposed to be claiming money from the SHA fund.
Yeah. That's very, very true. But then again,
and what I'm saying, and what I'm saying is that,
I'm like, but I have RUPHA here.
No, but what I'm saying is that SHA knows. You see these level 2 hospitals that are not supposed to claim from the SHA fund, but have claimed 2.9 billion. SHA knows them one by one, the entire list. And SHA has been paying some of them. I will shock you. I have data here for a level 2 hospital in Nyeri, okay, that has been paid 99 million.
Private.
Mission.
Okay.
Faith-based.
RUPHA?
To be
Is it
exact,
for primary healthcare or for SHIF?
SHIF.
That's the contention. Again,
so
RUPHA member?
They are not a RUPHA member. It's a mission hospital. They have been paid 99 million. Now, chances are, if you ask them, maybe they can explain themselves. But
they don't offer inpatient services.
But it's not like they did robbery. They went to the SHA account and picked 99 million, walked out. SHA, voluntarily. Somebody clicked a button and can see on the dashboard, this is clearly level 2. Somebody clicked a button and
approved. In a minute, tell us about what happens now. Is it a 14-day ultimatum? Right. In a minute, what happens next?
So we have 76 billion shillings in debt as a sector, 33 billion NHIF debt, and 43 billion SHA liability. Now, the health sector cannot continue bearing this burden. What we are saying is this: very simple. If this money, like for instance the 33 billion NHIF debt, if it is not paid immediately, we are trying to tell the Kenyan people that it is very likely by December, either you will not have hospitals, these private hospitals where 80% of lower level people go, either you will not have them, or the entire system will revert to 100% cash. Now, the reason why we are giving this notice is not because, as I said, we want SHA we like SHA. But in fact, we are giving this notice because we are scared that SHA will collapse. Because if this is not sorted and all hospitals, at least the ones on the private and faith-based, start asking Kenyans to pay out of pocket, you will have a vicious cycle. Kenyans will be saying, I have SHA, but why am I paying out of pocket? And then Kenyans will stop contributing to SHA. Contributions will fall. The same SHA will now decline. So it is imperative for the president's promise to pay the debt that was outstanding to be actioned immediately. And we have gone further and said, even this issue of verification of NHIF debt. 10% of the NHIF debt is owned by 2 hospitals, MTRH and KNH, government hospitals. So when people are saying we will not pay tax, we will not pay thieves, you are lumping KNH and MTRH in those ones. And in fact, those 2 owe the most debt. So if we are saying there are thugs and thieves in NHIF, we are basically saying Coast General is thugs, KNH is thugs, Nakuru County Referral are thugs, MTRH are thugs. These hospitals own 15.2 billion, half of the NHIF debt. So let the president maintain his promise. The health sector, I mean, I have sympathy for road contractors. I have sympathy for them. But road contractors, maybe life at stake. But the health system needs money for it to function.
Right. Let's leave it at that. I think this just needs a continuum of conversations and follow-ups, and we'll be listening more to what RUPHA will be saying. Dr. Brian Lishenga, chair of RUPHA, has been with us in studio.
And more on what RUPHA is doing within
the
I know we'll come back to the self-regulation.
Yes.
That's also critical.
Very important.
Next, we'll have Abdul Aziz Mohammed, a youth leader and politician. Mandera Politics Uncovered. The ground realities is what he wants to bring to our attention. It's coming up to 8:30.